live in Burlington, Vermont, and as you guys already know, Vermont was one of the early Medicaid waiver states. And when I started practicing, I was working for doing some work for the health department, and we were seeing a family where the dad never came to family meetings because he was a dairy farmer, lived about an hour and a half away, and the mom and the kids would come, but we really needed to see the dad. Nobody had ever taught us anything about Medicaid waivers and medical schools. One of the social workers in the health department said, you know, with the Medicaid waiver that we have, which is relatively new then, we can hire people to milk the cows on the dad's farm and bring him to the family meeting. So that was my first introduction to the potential flexibility and creativity of Medicaid. I've since learned that it's extremely important to really understand how the Medicaid system in your state works. And if you understand it well, there's tremendous capacity to get services for kids who really need it. And if you don't understand it well, then it can really become an impediment to accessing those services. So with that background, I'm happy to introduce Chris Kayanagi and Raphael Szymanski from the Bazelon Center for Mental Health Law here in Washington, and Carlotta McCleary with the Federation of Families in North Dakota, and Liz Sweet, who tells me that she works in Washington but actually lives in North Dakota as well. So, Chris? Sure. Sure.
Good morning, everybody.
Good morning.
And congratulations on coming to a workshop with such a boring title as Medicaid. What we're going to be talking about today is based on a report developed as a result of a Bazelon Center study. It's a 2-volume report, and friends here, I'm just about to bring it around to you. I'm going to give you a very short overview of why we've done this and why we think this whole piece is important. Then I'm going to hand off to Raphael, right here, who is the individual who did the research and the hard work to produce this information. He's going to try to give you a summary in a fairly short period of time. And then we're going to turn to Carlotta and Liz, who are both going to talk about how sitting out in a state with a family organization, material like this can be useful. And they're going to try to relate some academic presentations of myself and Raphael for you and how you can kind of run with this kind of information. So, without more ado, let me just give you a brief overview of why we think this kind of information is important to you and why it can change services in your state. Whether or not you are aware of it, your mental health system has become extraordinarily dependent on Medicaid resources. Maybe 20 years ago, when we wanted to look at what child mental health services should be out there in the community, we would turn to the state mental health authority, and if they had them, a person who dealt with child services within that authority, and try to lobby there to get more services. But states have recently spent a lot of time and energy seeking Medicaid reimbursement for everything they do in mental health. And this has been one way they've been able to grow their system, because once they bill Medicaid, they get a federal match of at least the same as what the state itself is spending on that particular service. So it greatly expands their resources. The downside of that is that then all the mental health services come under the Medicaid rules. And for a while, a lot of people were concerned that that was really going to constrain the flexibility in child mental health services. But state people have been fairly creative. They have found ways within the Medicaid rules, not perhaps to cover everything that we might need for children, but to cover a great deal more than traditional medical, clinical services. You can get a lot more under Medicaid than you ever could under a private insurance policy, for example. There's much more than an inpatient hospital and an outpatient clinic, even though it will not go all the way to fund all the support services that we would want for children and families. So it's an opportunity for us as advocates for children. The states are going in this direction anyway, to show our state the best way to expand Medicaid for child mental health services and to pick up on what some of the more innovative state programs have been able to do and start to replicate it in your own state. So that's the purpose behind this book. And as child advocates, you actually have something going for you that advocates for services for adults with mental illness don't have. And that is that the federal Medicaid statute has a very expansive mandate on states in terms of children's services. States must provide to any child who needs it any of the services listed in federal Medicaid law. Now for adults, some of those services are required, but some of them are optional. The state can decide not to have certain services for adults with mental illness. For children, the state doesn't have that option. There's a mandate in the states which goes by a series of initials. EPSDT. Have most of you heard of EPSDT? Early and periodic screening, diagnosis, and treatment. Treatment is that important mandate. EPSDT existed in a slightly different form before 1989. Then it was a mandate that states screen, diagnose, and provide the treatment that they provided to adults. They didn't have to have the whole array of treatment services. Only in '89 did Congress say every service that the government is willing to fund must be provided to a child. And there's been a bit of a slow pace of states changing over. And there are still states that will sometimes tell you, well, we have EPSDT children, and then we have other children. And that is a hangover from the old days. No, they don't. Every child who is Medicaid eligible is fully entitled to everything under EPSDT. You don't have to be labeled a special EPSDT child. So we're talking about all kids who need services being eligible for the services that are described in the state Medicaid plan. Now, one of the problems is that when the federal government says you have to have every service listed in federal law, they don't provide very expansive definitions of those services in federal law. So some states have tried to squeeze those definitions to be very, very narrow. Other states have been expansive and said you can do all these things under this title, say rehabilitation services, which is not well defined in federal law. However, the mandate, the legal mandate of Medicaid, is that if it is a definable service under federal law, and the federal government is paying for it, even if it's all the way across the country, comes a mandate that every state provide that service when an individual child needs it. The only control the state has is to say, well, this particular child doesn't need that. We'll give them something else. They can't say, well, North Carolina might cover that, but we're not going to. They cannot do that. So it becomes extremely important to look at what these innovative states have covered and go back to your own agencies, mental health, Medicaid, child welfare, and point out that your state could have that too. So what we have done, and what Raphael is going to describe more fully, is we have looked at every state's regulations and we've pulled out, particularly for the community services, which we're most interested in, which fall into this category of not being well defined federally. We've pulled out some good examples of rules and regulations from states with expansive coverage. That way, if you are successful in getting interest in your state in expanding Medicaid to cover that service, you can give state officials language which has been approved by Medicaid in some other region and by the federal Medicaid offices. So they're paying for it somewhere else under this language. So that can kind of jumpstart advocacy. You can show them exactly what language will work. A lot of times that can make their job a lot easier. So that's what we tried to do in the book, and we'll give you some of the details, as I said, from Raphael, and then I'll hand it over to Liz and Carlotta, who are going to talk about more of what they did in North Dakota, because North Dakota has expanded its Medicaid considerably, thanks, I think, in large part to the efforts of these ladies, and then we'll hope to have a lot of time to answer your questions. So Raphael, you want to take it from there?
Sure. David, could you help me?
We have one more handout. Highlighting some of the
Do you have any extra books? Because
I don't think we were expecting so many people. We have the thicker book, Making Sense of Medicaid. We have some extra copies.
Could we have?
Yeah, either one, if you can give me a piece of paper with your name and which book you didn't get. There's two.
Thicker.
Volume 2.
Volume 2, yeah.
yeah.
Give everyone a ring.
Oh, no, I do need.
You do need to. We'll give Raphael's away at the end.
Sign, right?
To page 80, you can see the different types of services we looked at. We looked at community-based services, clinic services, and residential services. And we broke it out between managed care arrangements and fee-for-service. We looked at 68 different programs in all the states, which was a lot. And I think Chris underestimates the amount of work. This was an incredible amount of work. No one else knows this. No one else tries to, for mental health services, figure out what is exactly covered. A lot of states call it DTSCT services, and there's no more detail. Some states actually only cover a couple of things under this, and some states, in keeping with the legal requirements, are very vague about what they really cover. I guess I just want to refer to the handout and just give you kind of a high-level overview of what states are doing regarding these services. And I guess I want to leave some time for questions. I usually sit in the office talking to Medicaid officials, so I want to make sure that the information I provide to you is helpful. We looked at, if you look at page 2 of the handout, community-based services. And some states provide this through the clinic option, if you're familiar with the different medical options states can choose to do. Some do through the rehab option. We just combine them together as community-based services, which is any of the services that are more of the non-traditional services that don't take place in a mental health or a physician's office. So we looked at 14 community-based services: targeted case management, intensive home-based services, school-based day treatment in other places than the school, summer camps and programs, after-school activities, family support and wraparound, child respite care, therapeutic foster care, therapeutic nurseries, therapeutic preschool, independent living skill training, other independent living programs, and other psychosocial rehabilitation. I want you to stop and tell you a little bit about the method. We looked at the regulations for the fee-for-service of the traditional Medicaid programs in the states. We also got the managed care contracts as well as any amendments, and also the request for proposal. And when we got that, we looked through them to find out whether or not they specifically listed these services. And once we did that for community-based, clinic, and residential, we sent it to 2 people in each of the states. We sent it to the Medicaid office, hoping they would give it to the right person who knows mental health. And as you know, oftentimes the mental health Medicaid agency does not deal with mental health services. Sometimes there's a separate Department of Mental Health or Child, Youth, and Families that actually designs the services. So we also sent it to that agency as well. We have got an excellent response rate. 96% of the programs responded. For 1/3 of the programs, we got responses from both Medicaid and the other organizations, so we could compare, and oftentimes they didn't quite agree. And for the other programs, we got at least from 1 person. So this is pretty solid information. I guess the other thing that was important is we only covered common services covered if Medicaid paid for it. There's a lot of services that Medicaid doesn't pay for, but other states' funds pay for. So we did not include this in this project, just to let you know. So getting back to the community-based services, if you flip on to 2A, which is kind of a graph, you can kind of see that, as you would expect, Medicaid programs tend to cover the more traditional services, the case management, school-based, day treatment, and you start to see a really big drop for like home-based services. It's now only 66% of the programs. Independent living skills is down to 59%. And then you have a huge drop for family support, which is 36%. And the other services tend to be much lower than that. Summer programs, 11%, after school, 16%. So you can kind of see that Medicaid is really focused on the case management and some kind of day treatment program. And they really left a lot of gaps in kind of what children and families need to kind of live in the community. Page 3 just gives you a sense of kind of how many states, because we looked at programs that some states had a fee-for-service and a managed care program. So we looked at both. And so this just gives you a sense of how many states across the country cover the different services. 43 states cover case management, 42 states cover day treatment in other places in schools, 35 states cover intensive home-based services, 30 states independent living skills training, 30 states school-based day treatment, 20 states therapeutic foster care, 19 family support, 11 child respite, and all the other ones are like 3 to 5 states cover the other services, like therapy, nurseries, preschools, after-school programs, and summer camps. The other thing we did was kind of look at how services vary between fee-for-service and managed care programs. And a lot of states like managed care because it's given them a lot of flexibility to expand services to the family, expand services to the community. Some other states, though, have been really successful in expanding their traditional Medicaid services. You kind of see variations depending on which regional office is involved in approving the waiver. And so on 4A, Table 2, shows you the lighter bar is traditional Medicaid or fee-for-service, and the darker bar is managed care. And managed care provides more day treatment. 91% of managed care programs provide day treatment versus 74% of fee-for-service. More home-based services, 82% of managed care programs cover this compared to 56% of fee-for-service. And more child respite, 23% of managed care programs provide child respite versus 15% of fee-for-service. Fee-for-service tends to provide more case management. They provide 80% of the programs provide case management versus 73%. And there's a lot of areas where they're basically a tie. Almost the same cover independent living skills, 59%, family support, 36%, and school day treatment, about the same. So you kind of get a sense of what states have been able to do. And then going on to the clinic services, we looked at 11 clinic services, and these are pretty much the traditional services that mental health prefers to provide: individual, family, and group psychotherapy, family education regarding the child's disorder, substance abuse counseling, crisis intervention, partial hospitalization, medication management, general hospital outpatient care, and physician services. And the amazing thing about this is that they're almost covered by 90% or more of the programs cover these services. So these are much more widely available, and as you know, these are often not the services that you need, not the services that work, not the services that are really specialized around your unique situation. And if you go on to the next page, Table 3, gives you a high-level overview of kind of how common coverage is. And for some things, it's 100%. Therapy, 100% of the programs cover therapy. Physician services, 90%. And that probably has to do with some managed care programs. Sometimes the carve-outs don't cover physician services. It's still in the traditional Medicaid program. Crisis intervention is very commonly provided. But you can see that for substance abuse counseling, partial hospitalization, and family education, that it's less likely to be listed as a specific service in the States. And then residential services, we looked at on page 6. We looked at 5 residential services: general hospital, inpatient care, psychiatric hospital, residential treatment centers, group homes, and residential crisis intervention. And for these services, we only counted them if Medicaid paid for the room and board as well as the treatment. In a lot of states, Medicaid only pays for treatment, but does not pay for the room and board. On page 6A, Table 4, you can see that these are also fairly commonly covered. 90% of the programs cover psychiatric hospital or inpatient hospital. 56%, and that's a really big drop, cover residential treatment centers. And then there's another job for residential crisis intervention. We were looking at whether or not there's other options for when a child's in crisis than putting them into a large institution, and 40% of the states cover that, and then 34% cover group homes. So that's kind of my high-level overview of this. I just wanted to talk a little bit about what's in the book, because there's a lot of information in the book. Chris was talking about using other states' definitions of services to help your state draft language for that. And on page 33, chapter 5, we pulled out for the community-based and the family-centered services some of the good definitions. And we looked at wraparound package of services, team meetings, family support, respite services, summer camps and after-school and recreation programs. Parents, some states are actually allowing parents who have experience with children to be service case managers for other children, mentoring, home-based services, early intervention, and also services for young children, and independent living skills programs. We also looked at some innovative ways in states have pooled funding across different agencies to provide a full array of services. So that's in there. And then the other thing, in addition to what I presented on the tables, is starting in chapter 4 on page 19. We go over in much more detail the different services, what's covered. For residential and clinic, we look at comparisons between fee-for-service and managed care, because there are some areas where managed care may be better and some where fee-for-service is better. I guess I wanted to see if anyone had any questions specifically about the kind of more technical aspect of the book.
When your child is treated in a residential facility, what if you don't necessarily agree?
You're going through an appeal process through your state Medicaid.
But when your child's in a residential treatment program, you're talking time, and treatment. And I could show you a copy. Because I didn't send in a coupon. My name is Rhea, and I'm from Alaska Young Families Network. And I'm also a mother who's on the Welfare to Work program, and I also have a child with a severe emotional disorder, and I have a severe mental and emotional disorder myself. But it is so hard to get in. I'm trying not to give up hope, but to get the things that you need to have done. Why is it that the facilities have the right to say what services need to be provided and paid for, and the parent doesn't when those services are not meeting our needs?
One of the problems in Medicaid is the lack of some of the covered services, even when they're in the state plan. So even if you get the rules correct, you have the problem of whether or not the services exist anywhere near you.
Well, I already
have
moved
enough
800 miles away to put him in this program. That's where I had to send him to get treatment.
If your child is in the wrong program, from your point of view, the way to make a change, I think, is to go through the formal Medicaid state office appeals. But also, you would be strengthened if you had a program in mind as an alternative that agrees that they would take this on.
But it's getting but getting the Medicaid dollars to pay for that.
If you make an appeal to Medicaid, and they take a look at this case and decide they're wasting a lot of money, and that there is an alternative program that you would choose.
Well, she's just asking to be assessment at this point, actually. But she wants a second opinion.
Yeah, because when you don't necessarily, what they're doing isn't working, and that all of this money, to me, that's a waste of tax-paying dollars, and that's why these social welfare programs keep getting cut, because the monies aren't being appropriated in the way that they should be. And no reflection on this study or against whoever done this, but did they actually go to the consumers to see what the services that Medicaid is paying for?
That's a different question.
If
We
it was
want to
the same
explore
ones
next.
they needed.
We're hoping to do a study just like that, because we're very aware that even when you put these services in place in the state Medicaid plan, a lot of times you only sign them in the major metropolitan areas. And they'll only have 5 slots. But on an individual case, I don't know that, so I don't want to tell you that you can't, but Medicaid pays that assessment without you get prior agreement from the state Medicaid office that they will pay for a second opinion. I think that's an issue well worth dealing because they are wasting money. And if you can get to an official in the state office and really figure that out, the residential treatment program is happy to keep the child.
Oh, yeah.
That's not the place to go. So I would recommend that you go to the state Medicaid, through the state Medicaid appeals process. Every state Medicaid office must have an appeal system for you. You need to find that office.
And how long does the appeal usually take?
Well, that depends on the complexity of the issue. Something like this, it might be reasonably quick. But they will give you that information.
Doctor?
Yes, what scale did you use for your research? And
Here, it's really more of a Medicaid policy study. So what we did was we looked at the regulations for states' traditional fee-for-service as well as looking at the managed care contract. And then to confirm what we found, we talked a lot with officials in the state, whether it was the Medicaid official or someone at the Department of Mental Health, to kind of make sure that we understood what they were saying that they did. Because as you know, states have some very specific ways that they provide mental health services.
This lady has a similar situation. Well, she had to move out of state in order to get the proper help for her child. I have a child, I live in North Carolina. She's being treated in Virginia. Medicaid did approve for that treatment because we did not offer anything in North Carolina that could suffice to meet her needs. Now they're trying to get her back into North Carolina, but as I'm thinking, you know, if it didn't work before, what makes everyone think that we're going to find a place now? I mean, does it take moving out of state to a state that will meet your child's needs to get the services?
You don't answer that.
Legally, of course, it shouldn't, but the answer is that some states have much better developed community wellness services than others. So you should not have to do that between Medicaid and the school. You should be able to get the services that you desire, but it can take a great deal of struggle to do that, and sometimes requires getting legal assistance, which is terrible. These days there isn't that much legal services assistance around. So I don't want to advise people to start moving all over the country because I'm not sure I can tell you a state that is strong enough that you should all move there. But certainly it does. Medicaid varies state by state, even though under federal law every child should have access to all these services. But one of the reasons we have a book like this is that it does vary drastically state by state, and we need to change that. We need to expand the services.
if the state provides these services, but the services are full and there is no room for the child, what recourse or how can you then force or access services that have long waiting lists?
Again, this comes down to state-based advocacy to expand the services that are available. The state has the rules. The only way that an individual child can get the services if they're not available or there's a long waiting list is to make a legal issue of it with the state and have that entitlement. And states need the pressure to come through and develop more services. Another way to do it, though, is to try to get more resources out of the state budget as a family organization to lobby and pressure for more resources and expand those services more so waiting will come down. And we have David, you have some answers to some
Well, I have a question or an idea, which is, are there any states that have family advocacy groups within Medicaid? So, for example, in Vermont now we have some interesting new legislation. One is that all of the mental health centers have to have 51% consumers and family members of consumers on the boards. So if all of the funding for, we have $110 million for a state of 500,000 people going through the mental health centers. So the needs to be majority consumer and family member membership. On managed care, we have an independent appeals panel, which has would help you if Alaska had something like this, and if Medicaid was managed, and it's been put in place legislatively, and if there's a dispute, in some ways, I mean, I'm not an advocate for managed care, but if there's a managed Medicaid program, sometimes you can put more pressure on it, because it's not costing the state more dollars if they're going to deliver the service, and the state can force the managed Medicaid provider to deliver the services. But I would follow what Chris said, and I think the place to push advocacy is to get independent consumer provider panels and advocacy groups within Medicaid. There should be, my opinion is there should be someone in Alaska in Medicaid who is an ombudsperson who you could call and say, I need to figure out how to get a second opinion for my child. Help me figure out how to get it funded. And I think, you know, whatever we can do collectively to get someone like that in the state.
So there's really only one residential care facility in Alaska, and that's a subsidiary of Charter North. And it's always, and that's nothing saying nothing negative against Charter North by any means. But, you know, you don't have a choice. And I'm just thinking, if I had to move from Southeast up to Anchorage because that's where he was placed, or sent him down to, I think it was Intermountain in Idaho somewhere, you know, like I would really fit there too. But it's like, you know, they don't look at those kind of things, and I'm thinking for $138,000, if that hadn't been kept in our Southeast community, if we had a facility there, you know, that could service our children, it would have been nice, rather, because you go to get from Juneau to Anchorage, you go by boat and car, or plane, you don't drive, you know, it was so far away. And if they're willing to pay that, what do you have to do? What are the guidelines to get residential care in a place where there isn't any? Why are the guidelines so stringent if what these programs are doing isn't working? And we as parents know what does on the community level.
There's a lot of frustrating individual problems that lie in Medicaid. Overall, I think the answer is only, as stated, that we have to get organized strategic advocacy. We have to get first the right services properly defined in the Medicaid plans, which is what we're talking about today. We need individuals to pursue cases. We need to get together, pressure Medicaid agencies, pressure the state legislatures. State legislators would be very interested to get the state is wasting a lot of money on residential treatment services for one child when the parents themselves would prefer a less expensive community alternative, kind of thing, which really makes a good legislative issue. So I would encourage you also to go to your legislators. It's important to understand that, you know, for us sitting back here, all we can do is tell you where in your state you can pursue these things. Well, that's Medicaid is an opportunity for states and for us to get the services that we want funded. But we're all of us up here very aware that there are zillions of problems in the way of implementing, and it's going to be a long fight. I want to move on now so we can hear from the experience of North Dakota, and then we'll come back to questions again at the end. So, Liz, I think you were going to go first.
Good morning, my name is Liz Sweet, and I work for the federal government in the Center for Mental Health Services. And for many of you, I've had the opportunity to meet you because I am your federal project officer for one of the community comprehensive mental health programs. And for others, I'm your project officer as the statewide family network grantees. So for those of you to whom I am new, it's a pleasure to meet you. And for those of you who have the distinct displeasure or pleasure of having me as your project officer, it's nice to see you again. I've had the pleasure of working with Chris in this area. Chris has done the work and I've been able to ask the questions. When I first came into this work about 7 years ago now, Chris was at that point talking about EPSBT. I didn't even know what that acronym stood for. And so I was one of those persistent family members who, when there was a presentation, I would go and I would listen to Chris, and I would write down all of my questions, and afterwards I would come up and I would say, Chris, help me understand what this means. And Chris would very patiently walk me through that process. And the next presentation that she did, I would say, Chris, we went back and we did this, and this is how far we've gotten. What are we not doing right? And Chris would say, okay, this is the next little piece. And then I would go back and I would do that, and I'd come back and I'd say, Chris, something's not working. And the reality of what happened was that I heard a statement that for me, when I was working in the family movement, the statement that motivated me was one that Chris said, and I'll never forget it. Chris said, EPSDT is the gateway to children's mental health services. And I thought, whoa, the gateway to children's mental health services, what does that mean? And that truly is what motivated me to go back and see, number one, what did those letters mean? What did that acronym mean? Who was responsible for making sure that that program was carried out? And how did I need to help families access that whole plan? So in the state of North Dakota, what we did was we found 2 families who were willing to help us as an organization walk through that learning process of EPSDT. And so and we were all very frank with each other. They were frustrated because they weren't getting services, and we were frustrated because we didn't know how to help them. And so we both said, we are going to partner through this, and we're going to hang in there together until the end. And we don't know what it's going to look like on the other end, and we may not get to where your child's service delivery system needs to be. But if you hang in there with us, we'll hang in there with you, and we're going to walk through this process. So this family with this young man who is just absolutely the most wonderful human being, and his mom had been working long and hard to get services for him. We walked through this process with a case manager. And this to me is the most frustrating piece of everything that I have ever done. The case manager really, her heart was in the right place, and she really was trying to do well by this child. So we went in and we had the EPSDT screen, which is only supposed to have to be done by any medical professional. And so, first of all, you have to remind them of what is the definition in your state of any medical professional. What does that mean? Well, in the state of North Dakota, I'm a licensed addiction counselor. I'm a licensed professional counselor. Believe it or not, that makes me a medical professional. And as a mental health professional, licensed in the state of North Dakota, when I see a child that I believe needs a mental health assessment, I have that ability then to make a referral. So this case manager and I together were saying, this young man needs a mental health assessment, because in our state, EPSDT is very quick to do a healthy physical checkup. They're quick to do an eye exam, to do the dental exam, and then all of a sudden, the world stops. And I kept thinking, no, Chris told me, it's the gateway to mental health services. So I said, this young man needs a mental health assessment. And so we found the mental health professional who was appropriately credentialed to do that. And the next piece was going to be that mental health person then saying, with the appropriate credentialing, that what this young man needed was respite care for himself and his family. That was what we were looking for at that point. Everything was going along so well until the case manager called back about 2 weeks later and said, Liz, this didn't work. At the state level, they told us they kicked it out of the system. And I said, what does that mean, they kicked it out of the system? They said they're not going to pay for it. So we were coming back to a conference, and there's Chris, and I said, Chris, now what do we do? What happened? Why would they kick it out? What does that mean? And after a long time, and Chris said to me, I think what that means is your state doesn't have a billing mechanism. So I went back, and sure enough, what it means in our state is that at the state level where the billing and payments are done, get this, folks, there was nothing coded in the billing system that when it gets to that point, there is anything that triggers payment for that service. What it meant to the case manager when it came back as a kicked out billable, what that said to her in her day-to-day practice was, we can't do this. They aren't going to pay for it. And I said, Chris said, this is the gateway to mental health services. What do we have to do? So in North Dakota, we're lucky enough that we're a very small state, and we have access to public officials that I know other people don't have the luxury of being able to call and within a day get an appointment with. So it's a luxury that I really do appreciate. But we went and met with the Medicaid director. And I said, what does it mean that we don't have a coded system for these kinds of billable services? And he is a very kind man, and I would not want anyone to ever think anything but highly of him, but his eyes got about as big as saucers. It was like, who taught you those words? And I never said Chris Gorianagi taught me. But one of the things that it taught me was that as we are doing this work, unless we know the language, we're not going to get very far. Because when a case manager comes back and says, it didn't work, they're not going to pay for this, most of us are going to walk away and believe that that's the way it is. SDT for these kids in the site who are Medicaid eligible. And so every time that I go somewhere, Medicaid is the gateway to mental health services. How are you maximizing this? And it really is one of those pieces that we have a responsibility to learn as much about as we can. Now, one of the things that our Medicaid director said to me, it's one of those questions, I'm not done asking Chris questions. There are still questions that come up. And the question for today, for Chris from me, when we get to that point, is the Medicaid director said to me, I have to live within a budget. And the legislature only appropriates a certain amount of money for me for match from the state level. And so my question for Chris when we get to that point is, because these are mandated services, can they use that as an excuse? My budget has run out of money. And so hopefully that's that's the next step in the learning for me. And when it's a managed care system, can they use that same excuse? Well, the managed care company has X amount of dollars that's been appropriated and their contract is for X amount of money. Can they use money as an excuse for not providing a service? The other thing that I want to share with you, because this was a true learning, and Carlotta and I were giggling about that this morning up here, is in North Dakota, the program is no longer called EPSDT. Now it's called Health Tracks. And Carlotta said, Liz, just for historical purposes, do you know why they changed the name? And this truly is the cynic in me, and I will own it. I said, I think too many people learn the acronym EPSDT, and if you learn what to ask for, they'll have to provide it. So I said, I think they had to change the name so people wouldn't know what to ask for anymore. So in North Dakota, it's not EPSDT anymore, it's Health Tracks. So one of the things is in your state, figure out what is the name of the program, because it may not be called EPSDT anymore. The only people who may know it by that are the people who are at the state level in the Medicaid office, because all of you know the kind of turnaround and turnover in staff that you have at a county level. And so if you have new people who are eligibility workers coming in who only know the program as Health Tracks in North Dakota, and when people begin to learn that name and they change it too, they aren't going to know what you're talking about. So learn what is the name that they call this program in your state. And it did take a lot of work, and it took a lot of patience on the part of the Medicaid director with us and us with him to be able to say, I need more information. What's the next step? Where do I go? So I will turn it over to Carlotta, who will share with you what's happened in North Dakota since I left.
I have some overheads, so I'm going to see if I know how to operate this. I probably have some good, but I will
What North Dakota has done, the rest of the story is that this Medicaid director and with our partnership project in North Dakota really showing that good mental health services for children was making a difference. We were seeing less hospitalizations, we were seeing less of a need for residential treatment options, and the cost of those facilities had gone down, for the cost for Medicaid. So Medicaid said, ooh, this looks good. And so they decided that they would take a look at doing a waiver for our state to try and, not have to follow the rules, asking for that ability. And what they have done, and I think it's probably a little different than some of the other waivers, is they're going for an 1115 waiver, which I've been told is a demonstration one. And right now, where North Dakota is at in that process is literally the concept paper went into the federal government in June. It was a 4-page concept paper, and in July or October, an 8-page document of questions came back based on our on our concept paper. So that's where it's at in the process, is just there. We have not even applied for this waiver yet. But we decided that we would go ahead and plan what we needed to and really take a look forward at where we wanted to go and not be stopped in this process. So what we're looking at is the child is going to be child and family will be in the center, and this is really taking a look at the wraparound model. Child and family team will get together and determine what it is that the child and family are needing for services. And those services will all be costed out, because it was important to find out how much you're doing and where those money is being spent at. And then they're going to go to a regional team, and that regional team will approve the expenditure of those dollars. Right now it's all going into Medicaid at the state level to approve, which is a distance away from those child and family teams. So they are trying to bring it more down to the regional level. And then of course we have a state team. On the regional team, we're looking at having a mental health person from mental health. Education, there will be a person from education on the regional team. And again, because there's going to be many different school districts, that'll probably end up being a voted on person to go onto that regional team. They'll choose amongst themselves who they want to send. Child welfare in the counties, again, they'll choose a representative. I live in a region where there are 10 counties, so it'll be kind of fun to see who gets that one. I'm sure there'll be much wanted slots. Juvenile justice, the courts and DJS, and family members will be on these regional teams to decide what's going on. In the regions that have a reservation, we are going to have Native American representatives also on that regional team. On the state team, we have, I was looking, and I may have missed some too, but we have the Division of Juvenile Services on the state level team. We have our Department of Public Instruction. We have the Director of Child and Family Services. The Medicaid Director is there. The Mental Health Director is there. And a parent is also there, and I serve on that executive committee.
on the state level team. Yes.
Can you repeat that last, who all go into state level?
Okay. On the state team, you have a director of the Division of Juvenile Services, the director of the Department of Public Instruction, a director of Child and Family Services, the Medicaid director, and the director of mental health, and a parent.
Have you considered putting more than one parent on that? We're intending, we're trying to make it so that there's two parents that read the Tumblr to help educate each other and work with each other better.
Yes, and we've had lots of interesting discussions about that, even the parent participation at the regional level. When we talked about having two or more and asking for a youth, oh, we couldn't possibly. Do you know how much time that's going to take? And so you end up with those kinds of things, and we're really going to try and make sure that it's in there with the agreement, so that there is a big push for that.
It probably takes less time because they can educate each other.
Exactly, exactly.
How many families do you have on the regional team?
On the regional team right now, it is being debated. Again, this is a concept paper that's going in, and so we are at an early stage where we can push things more forward. That is, a parent is supposed to be on there. At one point it was 3 parents, and then 2 parents. Well, boy, so we're at 2. We're going to be pushing for more. I mean, that's kind of where it's at. They also end up with some local regional control issues versus the state, and so you end up with who's going to tell them to do that when we get to local level. What we're going to be doing is expanding the screening, the mental health screening that's being done. And Liz had mentioned that they had gone in and asked for this screen. Well, my son also had tried to go through at that time it was EPSDT, and then later it was Health Track. So we went through both. And a lot of times they didn't even know or have the mental health screen at all. And when we went through 2 different things where it was a doctor or also within the county to do, and there were 2 different screens there. The result of our screen was not necessarily an assessment or service delivery. We ended up with a prayer. I'll pray for you. So I just wondered how they built that one. Anyway, so what we're trying to do with this is really expand the screening, the mental health screening that's done for children. And yes, it would be great if all of our EPSDT screeners would actually do mental health screens, but we want to go even further than that. We wanted the screens to be done by people within the education system. We want screens done in the Division of Juvenile Services. We want them done in the courts. We want them done by doctors. We just want it out there for a lot of professionals to be using, so that no matter child welfare, no matter what system that the child goes into, that they are determining things about whether or not that child has a mental health need, so that they can take a look at it.
Do you guys have in mind a kind of model screen? How did you, if all these people can do it, you must...
So they will be looking at a 1-page screen that everyone can do. At the assessment level, also at the screening level, parents will be, one of our new services, and I'll get to that later, will really be the parent support that ends up being available for families. But at the screening level, to be able to have families talk to another family member about what does a mental health screen mean, what does an assessment mean, what are the pros, what are the cons, so that they can make an informed decision about whether or not this is something that they want to go forward with. The assessments are really going to be, again, the provider of choice. So if that family wants to have it done by the public agency, that would be fine. If they want to have it done privately, that would also be fine. So they're not going to limit that at all. Once the assessment comes down and they take a look at the fact that the child does in fact have a mental health concern and that does in fact need some services, families will be able to choose which level of service that they're needing for their child.
Some of the concern is that, you know, how much choice are they going to be able to have? That's being debated. And so we're really, you know, families do have choice. And so they've come up with a couple of different levels. What they're really trying to do is make it so that children can have an integrated team of people so that they can have that plan and everybody's planning together to really pull together a seamless system of care for that child. And so that would be the service level 2 in the intensive coordinated service delivery. And then really take a look at providing a wide range of community-based services in place for that. So that would be at that level. Yes?
How do you deal with, if a family comes in a crisis at maybe the intensive level, but ideally if the correct services are given in, it would go down to a lower intensive, lower need, lower level.
The families can go to a lesser intensive level. In North Dakota, however, families are really restricted with the level of any kind of a range of options of services. And so we have more families needing extensive services than what are getting them. And so it's really the reverse of that we're seeing, that families that need intensive services are not able to get them. They're getting lesser services, and then they're having to use very restrictive placements in order to get the services that they need. And so we're really trying to open up that option for those intensive community-based services so that they don't have to. You know, they either get the family therapy or the individual therapy and then hospitalization residence treatment. That's kind of the, you know, and so we're really trying to open, we have more families that are probably, you know, really, really, truly looking at getting into that level 2. I think real quick I'll go over some new services. Okay, and again, trying to do this. The concept paper is in. We're trying to be able to have psychosocial rehabilitation groups available for children, independent living skills available. Currently, Medicaid in our state is not covering it. Taking a look, I mean, years, that respite care, but that is a new service option for kids. And then parent support and training. We're taking a look, and we had looked at Kansas, of course, for their being able to get parent support and training paid for through Medicaid. And so we took a look at that, and the one thing that we've added to that is that there would be group parents, because a lot of times there's training and support within a group of parents, and so we would like to do it as a group as well as individually. And so that's something else that we're asking for. The parent support and training piece, again, is going to be available to families up at the screening level and at the assessment level, and again throughout the thing. It's very important that families continue to have that support made available to them throughout the whole process, even though they may be overwhelmed at the screening process or overwhelmed at the assessment process and not asked for it, that it continue to be added in there and asked if that's something that they're wishing to have. It's not just that you say yes or no and then you're done. We aren't going to do it. So we're really trying to make sure that that continues to be offered for families.
Is each wife have particular numbers that we should know them by, or?
Well, there are a couple of different kinds of waivers. There's 1115, which is your demonstration waiver, which is basically HICFA's allowing states to do that, to study it. So there's usually a large evaluation component to see how it's working. A lot of states do interviews with families about how things are working now. And then there's the freedom of choice waivers, and there's a lot of other waivers, which basically 1915, which allows people to be told they have to choose a managed care option, and they don't have a choice. And from the community, there's a lot of waivers. HIPAA has a lot of waivers. They have different regulatory numbers. The National Health Law Program, this website, which is healthlaw.org, has some good information about National Health Law Project. Yeah. We also summarize it in the book, too, in the beginning. It's healthlaw.org. Also, HICPA has its own website, which is hcfa.gov, and they go through the different types of waivers. You can see it. The first one is Can everyone read this?
And if you're fortunate enough to have a caseworker who works with you very well, they should be able to know, if we come to them with this stuff, they should be able to know about these kinds of things.
Actually, I think sometimes they don't. I have some friends who are social workers who work with Medicaid, and they often don't understand EPSDT, especially about the fact that it's any medically necessary service. I mean, I think that what happens is that I think what you're saying, Liz, is true. They don't understand the program any better than you do sometimes. So I think that part of your role, and I think why we did the book, is to really show you that all these services that are covered in those tables in the back, your state should be able to provide. Some states do have billing codes for these specific services. Some of the managed care, the public managed care systems, like in Oregon, actually Arizona, Kentucky, some of them have really good specific lists of services, others don't. And I think that's one of the reasons why having things listed is important, because at least then providers know what they're going to get paid, that they are going to get paid, that they can provide the service, because there's a lot of misinformation. Because I think what Liz was saying is true. States don't want you to know. They don't want their caseworkers to know. They don't want providers to know, because it will increase their budget potentially. I mean, it's hard to say. I mean, I think there's the trade-off. A lot of states have used managed care to reduce inpatient costs. But the other part of it is that they have to provide the community-based services. And I think what you're all probably feeling is that they're often not there. And for some of these reasons, because providers don't know that they should be able to get paid for it.
You can get foster care through the state unless you get custody of your child.
Where did you said that the peer support family people come in at the beginning to offer the choice and education to be informed consumers. Where do these people come from? Are they coming out of the county or out of their family group providing them, or where do these family members come from to offer the service?
You know, again, that's something that is being looked at. You know, for example, our North Dakota Federation of Families will be able to provide that parent-to-parent support. You know, whether or not you can say that that will be the only place, I don't know. There may be, you know, Mental Health Association may apply, and then have people trained in being able to do that. So, I mean, it would be, we're asking, the debate is kind of on whether or not that can be hired by an individual entity, like the mental health department can actually hire parents within. So that's kind of a debated issue within our state right now, too. We're really advocating that it be a separate, freestanding entity that is able to provide that support and advocacy for families, but still in discussion.
Do you have that support and advocacy defined so that a state, do you have a specific definition for that so that it's not a piece of paper given to a parent and that's considered support? You know, as far as information provided, you know, just a list of resources where it's more extensive. Do you have that spelled out in a way that we can use?
Well, you know, to be honest with you, the way it's spelled out in the definition would have been that handout where they talked about specifically what an individual child and family would need and how much information that would be individual, and so it wouldn't be spelled out exactly.
I was just going to jump in on page 37. We do have a family support definition from Kentucky's managed care program. I think one of the problems with family support is that oftentimes it can be very different depending on the family and the child. So a lot of the definitions are very broad and open-ended, but there are states that have been able to define family support in a way that's been approved by Medicaid.
And right now, what we did literally was borrow Kansas's and just add the group in there. And so we took a look at what they had put down. And Amy is here from Kansas, and she could answer questions as well.
When you say that you're still debating who's going to provide that family support, who's those parents, who's going to control those parents, is this something that will be debated in the legislature? I mean, it seems like a pretty slam dunk as a parent. It seems like a slam dunk that you won't be the fox controlling, watching the chicken coop, meaning I wouldn't want the state to provide parent support.
I think by having families involved in each one of the levels of the team, both the state and the regional team, that's how some things will being done based on those advisory. That's why it's important to have that family involvement at all those levels.
So I'm thinking, who would be those expert family members who have been down the road and who are now helping those who are just coming on board to learn the steps? Who will hire those people? I mean, who will determine who hired those people? And I just don't want the state deciding, oh yeah, we're going to have parent advocates for you and we're going to hire them.
And I think right now, what Carlotta is saying is the debate is around the credentialing of those parents and who is going to get to decide what credentials, what training, what certificate will they come out with at the end. Who is going to get to decide what that certificate entails and what it looks like. And Medicaid is going to decide whether or not they're going to pay for that process.
Kansas has something like you have to have a VA or BS or experience working with children, and also you have to go through, I think 40, at least this is on paper, 40 hours of training for that, for you to be able to do that.
That's how it is now, or that's what they're trying to do?
That is what it is in Kansas now. from what I understand.
Amy, could you go ahead and stand up and tell them what's...
I'm from Kansas, and I train what we call our parent support specialists. And in fact, I went to North Dakota and trained Carlotta and a group from the North Dakota Federation of Families so that they can do the same kind of training that I do. And it's actually 24 hours of training.
24.
And 12 of that is wraparound facilitation, and then 12 of it is 6 different components that we determine through a group of people with representatives from mental health centers and the Mental Health Association. We came up with a curriculum that we thought would address the needs of families. It's positive reinforcement, negotiation, school law, crisis planning, outcomes, and then what we call culture of a family with a child with serious emotional disturbance. And
Are they parents?
they are parents. They must
They're
be.
not professional.
They are not
What's
professional.
the VA about?
And I
I
don't
think
know.
that maybe, I think I may have been, there's also behavior management, and maybe that, this is just on the waiver documentation, behavior
Okay.
management and parents
Yeah.
what it is.
We have
case
to,
management.
we have to.
I'm sorry, I couldn't hear you.
Yeah.
Okay, up again. You know, really in North Dakota, the parent support specialist is really ahead of the game, again, because we have the curriculum, we have things defined. In care coordination, which would be the case management, that hasn't been clearly defined. And so the parent support specialist is really ahead of the game in North Dakota, and we feel pretty good about where we're at with that. And so they're going to be debating what real targeted case management and what a care coordinator really looks like and how, I mean, that's going to be a bigger debate than this because we are really ahead of the game here with the help of Kansas on this.
Does Kansas have a certification process for training?
Yes, yes.
And how long does that take?
Well, it's 24 hours of training, and the wraparound is 2 full days. That takes care of that. And then actually, what we have done in Kansas is we had 2 demonstration on-site training, and the rest of that was done totally by conference call because we're a very rural state, and each session is 2 hours. And we are, in a couple of weeks, going to take that training online now.
I was going to ask you, how can we get this information?
And we're working on that. We're almost ready to pilot that.
And is this through the Federation? You're doing this?
This is through Keys for Networking, which is my organization, the advocacy organization in Kansas.
And these are billable services under Medicaid?
Under our Medicaid waiver, that is a billable service.
Okay, one more question and we need to go on.
Actually, I just want to say that I think that not only, I think that there are a lot of people developing prevention and this kind of thing. In New York, we have the Family Development Prevention, which has recently been developed. So I think that's a great thing, and it's training for parents or others to do this work. So I think that everybody's in the midst of developing, or a lot of people are in the midst of developing some sort of prevention. And this is training for parents now in New York, and expected to be a college credit course in the future. And do they have to pass a test?
Yes.
Portfolio, there's a test, there's a test and portfolio requirements.
You know, back taking a look at I just thought that to have kind of an idea of the service level 1 and service level 2. Again, this is a draft because we're still really discussing where things are at. We've really focused in more on what we want on the service level 2 than we have the service level 1. And so this is the part that we're still deciding, how do we deal with a family that's in crisis and they need hospitalization, and what do we want to do with that so that we don't have that long wait for them to get the services that they're needing. And so we're thinking that we will, obviously they won't have to if it's an emergency, they're not really going to go through a team. We convene the team, after that emergency and then see if there are different ways and services that they're needing before. So again, this is really stuff that needs to still continue to be worked out. What they're really wanting, what Medicaid is really wanting to do is really have a team deciding what the services are that are needed for a child, again, to get out of those more restrictive types of placements that kids in North Dakota are getting sent to. And the team process is really a way of being innovative with those community services that kids really have not had the options for before. So a kid is not going to just be able to go in and say, hey, I want residential treatment, and go into their doctor and say, I want this, and then be able to do that. They will convene a team to take a look at options. Again, a doctor will not just be able to go to necessarily a family and say, your kid needs to be here, without really taking a look at some community options first. So again, it's really trying to take a look at making sure that some community options are being presented to families as a way of keeping them home. So, very much a draft.
Are there dollar amounts associated with each level?
Certainly the children within this level who would need the extensive treatment, there are more here. I don't know if they're really going to necessarily limit the number of individual sessions that a child is going to be able to get. I really don't know if we're going there yet. We're really taking a look at phasing this. We're having a pilot. The plan is to pilot this in the Fargo region, in one region, kind of take a look at how it's working out, and then move it on to the other regions that the partnership project was in, and then statewide once things have gotten in. So it's really, this is kind of like, it's going to be a process of stepping and expanding to see where we're at.
A lot of the things that you're talking about is in the managed care plan, in the contract. And if parents are involved in reading that contract,
We don't have managed care in North Dakota and this is what we're trying to do with Medicaid instead of having somebody come in. So we really don't, North Dakota does not have managed care yet.
Within your state does have managed care. A lot of this is covered in that contract language, and it's really beneficial for families to get a hold of the contract before it's led to the contractors and read it to make sure that what's in there is something they can live with. And if it isn't, then they need to go to their mental health authority to say this is not compliant.
How many people in your circle?
I don't know the numbers.
We have about 5,500. When you look at when we use the federal language of severe emotional disturbances, it's about 5,500 kids. We are a very small, very rural state. We have 53 counties, 3 of which have not had a live birth in the last 3 years. So it's an aging, it's an aging state. We can only envy Utah.
Okay, I think we've had a good perspective from different points of view here, and I want to emphasize again that there's a lot of problems on Medicaid, but it is, as I think North Dakota illustrates, and Kansas and some other states as well, a great opportunity for advocacy and expansion of the kinds of services that we want. There are some constraints on Medicaid. There are things that even with a waiver you're going to have trouble getting. One of the issues is that whatever service is covered must be focused as an endpoint on improving the child's condition and improving the child's functioning. So if you're going to do respite care, it has to be really clear that it's necessary in order to stabilize that child to live in the home. It's not just an opportunity for the parents to get recreation. Although to us those things are so connected, but the policymakers sometimes that's a leap they don't quite make. So the words that are used in a state are very important, which is why we've got the examples in the book. The way respite care is described in some of those states is the way you need to do it. The way family support is covered is sort of the way you need to do it. So I think there's obviously a lot that could be done with Medicaid. I want to answer that question that Liz posed to me because it's a very important one. Can the states say that despite all their good intentions, they just don't have enough money? And if we're talking about children who have a mandated array of benefits, the answer is they cannot say that. They have to find the money if the child needs the service. Now, unfortunately, as advocates, it's still an uphill fight. And in many cases, we've had class action suits, or we've had individual suits for individual children before the state loosens those purse strings. So I don't want to pretend that this is easy. It is not. And it does take concerted advocacy. It takes doing what Liz and Carlotta did as well. It takes working with state officials. State mental health folks are usually your allies. State Medicaid offices are much more difficult to work with. But all legislators also will respond if you can clearly make the case that the state is wasting money by letting kids get to crisis and providing services in intensive settings or in crisis mode when far more cost-effective services could have been provided. But it's a long fight, even in the states that now have good rules. Some of them, as I say, went the legal route and had a class action suit like Pennsylvania, and others just took a long time and a great deal of advocacy by the state mental health authority working with advocates to get the services in place. So I don't want you to think that we're trying to say it's easy. We know it's not. And we hope that we've given you useful tools to do what you need to do. We have about 10 minutes, so we can take a few more questions. Let's start at the back.
I want to know if, and I'm thinking of a specific child who receives services from Medicaid and has been put on a waiting list for a special treatment facility and told that this is a 9-month waiting list. The child is always in crisis, and I want to know the best
state to get that kid itself.
Okay. Let's go back to where we were at the beginning of the session. If the service is covered clearly and the issue is not, if you haven't got good definitions or building codes or whatever, you're having a struggle with a particular child who's getting the wrong service, you should first of all start with the Medicaid office appeals process. And I would encourage, if you see this as a pattern, as a family group, you see this as a pattern, I would encourage going to the Medicaid director, going to the mental health director, and going to the legislative committees and saying, we're seeing this over and over again. It's unproductive for us to take every child through an appeal or to get a lawyer and sue the state for individual children who then can jump a waiting list over other children who look just the same. What are we doing here? And try to get this to be a major mental health policy issue in the state. It's, in the end, you know, fighting child by child, you just are fighting the same battles over and over. For the immediate crisis, if you're facing a family and a child, help them get to do an appeal and to make the best fight they can individually. But as advocacy groups, try to see where the trends are and begin to take concrete issues to the policymakers, and don't take too many at once, but you know, make the case that we're wasting money on these kinds of services because we're not catching children early, we're not giving families support, we're not doing these other things. And look at these other states that have done it and put these provisions into our rules and let the providers develop in the community to provide the services that families are looking for.
Does the argument we are sending our children out of state because we don't have the facilities in state, does that count to them, to the legislators? Because we recently made the argument of, you know, you're sending your kids here and we're paying all this money out of state where we can have this in state and employ people.
Here's what you need to look at in your state. The most important thing that you do is make sure that you have done your homework with families, and if there are multiple family organizations in your state, you have to, as a group, come to consensus. You cannot go to a legislative body and have two groups who do not agree on what is to be done. It will kill the process right there. So you have to, as a state of multiple family organizations, come to consensus. Bottom line, bar none. The next thing that you have to do is when there are many, many kids going out of state. In North Dakota, what worked was we did say, this is an economic development issue for our state. And that's the buzzword that legislators understood. And when we talked to them in that piece of language about economic development, in a state that was sending away its tax dollar, they took note. And so that was how we continued to frame the information. Did it mean that we really saw that as the focus? No, but we used the language that they were interested in to get our agenda met. The other thing is that in North Dakota, our legislature only meets every other year. So we have a year where the session is on, and then we have what we call an interim year where committees meet and there's legislative education. And so it's a 2-year legislative process. And when we started this work, I had the Speaker of the House at that point who was an ally and said to me, Liz, I will help you through every step of the way if you make me a promise. And so he and I went to lunch and we talked about what it is that each one of us needed, and he said, Liz, I will help you if you promise me you understand that this is an incremental process. You and I can agree in the end this is what we want to see. But this year the only thing that we can do is raise awareness. And if we get the bill to be an interim study, we will have succeeded. Then you have this year and next year to educate legislators about why this is an issue. Next year we come back and we get a little tiny piece of what we want beyond the study resolution. And we did that. And then the next session, and he was very frank with me. He said, Liz, this is a 7-session process. In North Dakota, that meant 14 years, which meant that we as family members who were doing this work had to be very, very upfront and blunt with the people, the families that we were working with. My child was never going to benefit from what we were doing. He would be out of the system and would be an adult by the time this was done. But it was a committed group of families who said, I don't want this to happen to anyone else's child, and in the meantime, we're going to hang together and we're going to stick together, and we are not going to let anyone do a divide and conquer. And so it has been very incremental. And that's why we're at this point now. It's not the end product, but it wasn't where we started. And in another 2 sessions, we'll probably look even better than we do now. But if you go into this, you really, truly, when families come to me and they say, what's the most important thing that I can do around my own child's mental health? I look at them and I say, you have to become politically involved in your state. And they look at me like, what does politics have to do with my child's mental health? Folks, this is where it happens, and you have got to be able to do this. Children are not a partisan issue, but you've got to have families from both sides of the aisle, because when you've got one legislator who's hanging up the process, you've got to have somebody from his party who is a family member who votes in his district, who can go to him and say, I am your constituent. This is why this issue is important to me. And he will listen to that person when he won't listen to me, who lives halfway across the state. So it's incremental.
You may have said this and I didn't understand it. But I'm trying to figure out how you get financed in order to take the time to do this. What is Child, Adolescent, and Family Branch of the Center for Mental Health Services?
The Center for Mental Health Services is divided into 3 centers. The Center for Mental Health Services is one of those within SAMHSA. Within the center, there are branches that have specific pieces of work to do. In the Child, Adolescent, and Family branch, our focus is on kids and families with mental health
So
issues.
are you a state employee? Or are you
I'm a federal employee. I'm a federal
Okay.
employee who used to do this work in North Dakota, and that's where my passion for doing it came from. Now, as a federal employee, I don't get to do any of this anymore.
Well, who's paying you to do? I mean, it's like, where do you get the funding? Because it's like, this is a full-time job. This is a full-time job for more than one person. How do you do it and still maintain your objectivity? I mean, are you a state employee, or do you have some special funding, a grant or something that's enabling you to do this?
The family organization, the Federation of Families in North Dakota, is where I work. It's not for a specific agency, and they've got multiple grants and different things that they look at for funding for sustaining the family organization.
So it's something that could be duplicated in my state, which is Missouri. If we wanted to do it, we could do it.
You could, and you can hook up also with other child advocacy groups if you can find them. There's always politics. It always works in our business to have coalitions. Lots of other groups that will support you. Sometimes the provider groups, depending if they're the right provider groups, will support you as well. Before we take the next question, I want to make sure that we get every list of people who want the books back
You
up
might give
here.
us the start of a second list.
Somebody have.
I only have one.
Okay,
And before people